Hi, group. This week we're talking about antibiotic stewardship, which is a really important topic to me, being a burn ICU nurse. We have a lot of patients with some extremely virulent strains of the antibiotic resistant organisms, and we have to treat them with some really heavy hitters. So it gets kind of interesting from that regard. Basically, in a nutshell, antibiotic stewardship means to use it wisely. It means not to prescribe without actual bacterial infections present in a healthy population. It means using culture and sensitivity to get the specific antibiotic that's going to work best for the strain involved. And good patient teaching is also very important, to teach one to finish all the antibiotics, because when you don't finish the course, you may not eradicate all the bacteria and the resistant ones can flourish. Additionally, it's important to teach patients that an antibiotic isn't necessary for every cold or every illness, that a lot of the things that we get commonly are viral and antibiotics don't work for that. As consumers, it's important that we're open to those things from our healthcare providers, and that we listen to what they say about whether or not something needs antibiotics or is a viral infection, and won't respond to that. So in my clinical practice, as I said, I'm in the burn ICU. It's such a unique area because the patient's first line of defense, the skin, is gone, especially in very large burns. And the question really isn't, will they get septic, but when and how many times. We deal with long-term ventilated patients who have multiple episodes of ventilator-associated pneumonia. We get patients that have bacteremia, bloodstream fungal infections, and all kinds of things like that from many multi-drug resistant organisms. A standard protocol for our patients is this 3-drug combination of voriconazole, vancomycin, and meropenem that pretty much everybody is on. And from a prophylactic standpoint, if they're a big burn that had any kind of indication that the wound has become cellulitic in any way. We also use topicals like silver sulfadiazine, bacitracin, polymyxin neomycin solutions, mafenide, and topical amphotericin for different skin surface infections from the wounds. We have currently in the unit MRSA, VRE, carbapenem-resistant Enterobacter, multi-drug resistant Pseudomonas. We also have multi-drug resistant Acinetobacter, and all of those things are in actually most of the patients on the unit. There are a few patients that have them all. We have multiple patients typically that are in kidney failure from the antibiotics used for these infections. We have a lot of the continual renal replacement therapy patients on our unit at any given time. And MRSA for us is just pretty much normal. Almost everybody has that. We see an awful lot of multi-drug resistant Pseudomonas. We use a lot of colistin for that. We use tobramycin and amikacin for some of the more refractory cases. Or frequently what will happen is somebody will get MDR Pseudomonas, we'll give them the colistin, the infection will resolve, and then it will return, and then it's no longer susceptible to the colistin, which is basically textbook antibiotic resistance development from organisms in action. Only the resistant organisms survived, and it might have only been 1 or 2, and they ultimately replicated and overwhelmed the patient's system again. So we need another agent, a new agent, a more toxic agent to battle the next infection. CRE is one of the things we particularly worry about because it is so difficult to kill. Currently in the unit, the carbapenem-resistant Enterobacter is susceptible to the gentamicin, but really nothing else. That's all we've been able to give for that. And we have we have people that will go home for the rest of their lives probably on dialysis because of what the gentamicin has done to their kidneys. We get a lot of fungal bloodstream infections and end up with IV amphotericin B. That's another very toxic, nephrotoxic agent. Another big concern for us is MDR Acinetobacter, which is an interesting story because we get Army patients. And there's been some very well documented cases from Walter Reed and from Landstuhl in Germany where soldiers that have been in Iraq or were injured in Iraq in the last 10 years or so are colonized with this MDR Acinetobacter, and then they get sick or injured or whatever, and they succumb to the infection. It has also turned into a hospital-acquired infection for people who did not have it but were in the hospital at the same time as some of these soldiers. Well, we had some of those soldiers on our unit, and we still, 10 years later, are still battling the MDR Acinetobacter from that incidence. We give a lot of imipenem and colistin for that. The hard thing about the MDR Acinetobacter is that it lives on surfaces for 3 weeks or so, and it's very hard to kill in just normal room cleaning. One of the things our unit has for this is when we move patients from room to room or discharge, they clean the rooms with bleach twice, and we also, in between the 2 cleanings, have a infrared light. Its name is Trudy. I don't know what it stands for, but it's like a tanning bed standing on its end, and they shine it in the room for I think an hour or so, and it sounds like you smell the ozone and you hear it like one of those bug zapper things. And it's supposed to irradiate the room and clean some of the surfaces that may have gotten missed. One of the ways that we deal with this is all of our patients are on isolation precautions. We all wear gowns and gloves into every room. Whenever wound care is performed or wounds are exposed, it's gowns, and they're plastic, impervious gowns. I sweat off 10 pounds every time I go to work. We wear the gowns, we wear gloves, we wear masks, we wear hats, we wear shoe covers. Our scrubs don't leave the unit. We also cohort patients based on the infection that they have, so our rooms are kind of separated. All the patients with CRE are at one end of the unit, all the patients with MDR Acinetobacter are at another corner, all the patients with the MDR Pseudomonas are in yet another corner, and we try to limit personnel coming in and out of the rooms by, if you're a nurse and your patient has the CRE, those are the only rooms you can go in. You can't go in any of the others. So they don't want anybody taking anything in on a shoe, on a pant cuff, on a pen, on a wedding ring, or anything like that. And also all of our non-durable medical equipment is, once it goes in the patient's room, it doesn't come out again unless it's coming out in the trash to be incinerated. We don't recycle anything. We don't keep anything. Everything goes to the landfill to be burned. So, infection control is a major, major issue on the unit. And it's really seems quite interesting because it's one of the things that we battle with pretty much constantly. The burns themselves, they heal, but it's the sepsis that kills our patients. And, it's a very big deal. And the antibiotic stewardship is really how we're going to prevent more and more organisms from becoming a danger in the future.